Hello, everyone. My name is Stephanie Eldred, and I'm with the Center for Best Practices. Thank you for joining us today for the Engage the Healthcare Community to Support Summer Meals webinar. Before we get started, I have a few housekeeping items that I'd like to go over. First, attendees are in listen-only mode, and we will be recording this webinar today. We will take questions during the webinar. Please use the question box for your questions, and we will read them out loud. And we will also respond to them individually. We will circulate the webinar recording and resources later this week. So, without further ado, I would like to introduce my colleague, Derek Lambert, to start the webinar.
Hello, everyone. Thanks for joining us for this month's Schools Out, Foods In Summer Meals webinar presented by the No Kid Hungry Center for Best Practices. Stephanie, thanks so much for the introduction. And we are excited today to talk about ways that healthcare institutions can support or even implement summer nutrition programs on their campuses. We're going to get some great insights from our expert panel today. I want to, on the next slide, remind folks about the Schools Out, Foods In webinar series calendar. Today, we have our webinar on the healthcare community. This is a monthly webinar that continues through June. At the end of today's webinar, you'll see the time and date for our webinar for universities. It will include a link to register. So you can go to our website and register, or when you get the slide deck, you can click on that link and register for next month's webinar as soon as possible. We are excited to continue the conversation as we discuss universities, summer meals at public housing facilities, and at non-traditional sites. This webinar series is graciously supported by the Arby's Foundation, our funder for this project. On the next slide, I'd like to highlight that the Center for Best Practices has a new website, bestpractices.nokidhungry.org. Lots of great resources, lots of information about the programs that we support, including school breakfast, after school meals, and summer meals. Some of this stuff will be familiar, but it's a great, beautiful presentation. So please visit us at bestpractices.nokidhungry.org to take advantage of that resource. And for today, we're going to go over our agenda. We're going to do a brief audience poll and introduce our panel. Then, with support from USDA, to frame the discussion, we'll understand some basics about summer meals and how it applies in the healthcare context. And we will learn about existing delivery models from our friends at the Medical University of South Carolina and our colleague and panelist, Debbie Puttipane. And then we will look at a case study from University Hospitals Cleveland Medical Center with Ann Leach and Dan Ballard. But before we get on with that, we're going to have a couple of audience polls. And Stephanie, let's have a look at the next slide and the poll question. We're going to hear from folks that are on the line today. Which category most closely matches the organization you represent? Are you a summer meals sponsor or site, a USDA or state agency, a community nonprofit or advocacy organization, a healthcare institution, or a food service manager or director? So Stephanie, let's go ahead and launch that poll. Give our audience a chance to respond. We're going to give folks about 10 seconds to answer this question about which category most closely matches the organization that you represent. So let's give folks about 5 more seconds. So Stephanie, let's close the poll and see what the results are. And Stephanie, what do we have?
All right, so it looks like we have about 32% said summer meals a sponsor in the site, 14% said USDA state agency, 41% being the most said community nonprofit or advocacy organization, and then 3% are healthcare institutions, and 10% are food service managers or directors. Okay,
great. That's a nice mix. And what I hear from this, Stephanie, is that there's a lot of stakeholders in this audience today. We got folks from all different aspects of the program that could really bring an important voice to the conversation in their communities about bringing meals to healthcare institutions. Let's look at the next slide and another poll. When it comes to serving meals in a healthcare setting, which statement most closely describes you? Number 1, we already serve meals in a healthcare setting. Number 2, we've seen this model in action, but we don't currently participate. Number 3, I've heard of this, but I've never seen it. And number 4, this is completely new to me. So we're going to give folks about 10 more seconds. Again, Stephanie's already launched the poll, so feel free to click the one that most closely represents your perspective. And Stephanie, let's give folks about 5 more seconds, and then we'll close the poll and see where we're at.
All right.
Okay, go ahead and close. And what do we have, Stephanie?
So it looks like 15% said we already serve meals there. 11% said seen this model in action but don't participate. 38% said heard of this but never seen it. And then 37%, this is completely new to me.
Okay, so it sounds like 85% of the folks on the line today are not currently implementing this model. Maybe they've seen it, maybe they haven't, but there's a lot of ground out there to cover in terms of helping folks understand what this could look like, what are some of the operational implications, and from a regulatory perspective, how do they work with their state agency, how do they work within the current regulatory structure to bring this model into play. Very interesting. Thanks so much, Stephanie, and thanks to our audience for participating in the polls. I want to give a really special welcome to our panelists who I mentioned briefly earlier. We have Emily Delahanty from USDA, Debbie Puttipane from Sodexo Wellness Dietitian from the Medical University of South Carolina, Ann Leach and Dan Ballard, employees with Sodexo who work with University Hospitals Cleveland Medical Center. We'll give more full bios for each of these folks as their line in the agenda comes up. But just want to give a special welcome and recognition to these folks for taking time, contributing to this agenda today, and for all the expertise and experience they're going to share with us. And on the next slide, I'd like to remind folks that this is a moderated panel. So if you have questions or comments during the webinar, you don't have to wait until the end. You don't have to wait until we pause. You can chat those in immediately, and my colleague Stephanie Eldred will triage those as we go. And when we do get to the question and answer sessions, we will give preference to audience questions to try to make sure that your interests and concerns are given expression at the webinar. So as you can see there, click into the questions box, enter your question for staff, and Stephanie will be happy to help out. So without further ado, I'm going to go ahead and turn it over to Emily Delahanty, who is a program analyst at USDA's Food Nutrition Services Child Nutrition Programs, specializing in summer meals programs. She entered the federal government as a Presidential Management Fellow at the USDA's Office of Budget and Program Analysis, and she joined Food and Nutrition Service in 2015. Emily, it's been a pleasure to work with you in the past, and I want to thank you so much for joining us on today's webinar.
Thank you so much for that introduction, Derek. And I just want to start out by saying how excited I am for the opportunity to present today. Like Derek mentioned, I am a specialist in the Summer Food Service Program. I could talk about it all day, every day, but I will attempt to keep my presentation to around 9 minutes for you guys today. I'm really excited that the majority of you have not really heard that much about the summer program, so I'm very fortunate to be able to be the one that gets to introduce it to you from USDA's perspective. Summer meals are so vitally important to making sure that kids have the nutrition that they need when school is not in session. And as you will hear from all of the wonderful panelists today, making sure that kids are well fed provides them with the opportunity to continue to grow and be ready to learn when school gets back and to build healthy eating habits. So on my first slide here, I just want to start off with a quick bird's eye view of healthcare facilities that participated in summer in 2017. As you can see, there are hospitals and healthcare centers all across the country that have made this connection that providing kids with nutritious meals when they are not in school fits really well into the mission of any hospital or healthcare center that wants to promote healthy habits within the community. FNS is really excited about the opportunities to connect kids to meals in healthcare settings all over the place, and hopefully many of you will be inspired today to go back and implement this in your communities. On my next slide, I will tackle the first big question, which is what are summer meals? Sometimes you might hear people refer to summer meals and the Summer Food Service Program and use them interchangeably. When we refer to summer meal programs, we're actually talking about the 3 different options for serving meals during the summertime. And those 3 options include the Summer Food Service Program, which is the traditional summer program. It also includes the National School Lunch Program, and that is typically used specifically for schools that are implementing a summer school curriculum. The third option is the Seamless Summer option that allows schools to continue to serve meals to the whole community during the summer months. For the most part, any hospitals or healthcare facilities will be operating and working under the traditional SFSP program. So on my next slide, I will talk about how the program actually works. So the SFSP is a federally funded, state administered, and locally operated program. there are three major players in the summer food service program: state agencies, sponsors, and sites. So first of all, your state agency. State agencies are responsible for doing all of the administrative requirements for the program. To participate in the SFSP, sponsors have to sign an agreement with the state agency outlining the roles and responsibilities of each party. Every state agency is different, so to get the most precise information, you'll want to work closely with your state agency in the state that you reside. The state is also responsible for providing training and technical assistance to all sponsors. States want their sponsors to succeed and operate the program with integrity, so they typically take every step necessary to assist both new and experienced sponsors. So for those of you who have not participated in the program or don't know that much about it, your state agency is really going to be your go-to place to learn more about how to participate, how to apply, what roles and responsibilities there are. State agencies are also responsible for monitoring the operations of participating sponsor organizations. So sponsors are responsible for a wide range of functions. First of all, a sponsor will accept all financial and administrative responsibility for the program. They also manage the food service. So this means that they are responsible for the food preparation or having the capability to oversee a food service management contract. Sponsors are also responsible for training sites and their personnel, arranging for meals at each site, and making sure that those meals meet the USDA nutrition standards. They also supervise and monitor the operations at each of their feeding sites and assure that all paperwork is completed in an accurate and timely manner. And they also submit claims to state agency, which is the most important part because that is how sponsors get reimbursed for the meals that they serve. And then lastly, we have the actual site, and this is the space where kids will go to receive meals in a safe and supervised setting. This is where the rubber meets the road, is at the sites, and your local communities are responsible for figuring out where those sites are and where they would be most beneficial. On the next slide, I'll talk a little bit more in depth about some of the roles and responsibilities of the sponsors. So sponsors really can be any type of different organization. It can be a local government entity, a school food authority, a park and recreation agency, or a hospital or healthcare facility. As I mentioned on the previous slide, sponsors handle the financial, administrative, and food service responsibilities of running the summer food service program. On the next slide, I will discuss a little bit more in depth about the sites. So like I said, sites can be indoors, outdoors, in a whole host of different places. You can get really creative in where you place a summer site because they can really take place anywhere. When thinking about where to locate a site, you'll want to consider where children naturally congregate in your community. So in a hospital, it might be the cafeteria, or there might be a playground somewhere on the hospital grounds, or something like that, or a clinic that focuses particularly on children. So you want to think through those aspects of where you want to actually locate the food service. And one thing to note is that for those of you that are new to the program, we do recommend starting operating the program as a site and really learning how the program should be run properly rather than just jumping into all of the administrative responsibilities of operating the program as a sponsor. So on the next slide, I'll talk a little bit about the different types of sites. So sites can be classified in a number of different ways, and each is aimed at a distinct population and with some different eligibility requirements. So we have open sites, open restricted sites, closed enrolled sites, camps, and migrant sites. And these different types of sites are all defined in the program regulations that govern the program. Open sites are open to all children in a community. Any kid can come in and get a free meal. Restricted open sites are typically those that are open to the community, but on a first-come, first-served basis. A restricted open site would typically have some sort of fire code restriction that would limit the number of kids that that particular site could serve. A closed enrolled site is for a specifically identified group of children, such as those enrolled in a specific type of summer camp or something like that. Camps are very clearly defined in our regulations, and the added benefit of being classified as a camp is that you can serve 3 meals a day at campsites, and migrant sites serve primarily children of migrant families. If you are considering participating as a site, you should really work with a sponsor and your state agency to determine which type of site would best suit your capability, your resources, and the needs of your community. So on the next slide, I'll talk about the eligibility requirements. The Summer Food Service Program is a little bit different than some of the other USDA food programs. Whereas in a traditional school lunch setting, the eligibility would lie with that particular child and their family. In the Summer Food Service Program, eligibility is determined based on the area in which the site is located. So any area in which at least 50% of children are eligible for free and reduced price meals can have a summer site. And you can determine this eligibility using school data or census data. Other types of approved data can also be used to determine eligibility. This includes data from departments of welfare services, zoning commissions, housing and urban development housing authorities, and other local housing authorities. In some instances, we have utilized Medicaid data in order to determine that a site is eligible. You should work with your state agency to determine eligibility using some other data sources if the more traditional methods don't necessarily work for your site, but you are serving a population that is low income. You can also collect income eligibility applications. The child must qualify for free or reduced price meals in order to receive a free meal. And any child under 18 can come in, 18 and under, can come in and receive a meal at no cost at our open sites or open restricted sites. For more information about eligibility, you can check out our memo. It is entitled Area Eligibility in Child Nutrition Programs, and I can send that link on to Derek so he can share that out after the presentation. On the next slide, I'm going to talk about one of the requirements of the program that tends to trip people up a little bit, especially in hospital and healthcare settings. And I'm going to get a little bit nerdy and wonky about the statutory authority of the program for a second, so if you will indulge me. The stated authority of this program since its inception in 1975 has been to initiate and maintain a nonprofit food service program for children in institutions. And it defines a service institution as those that develop special summer or school vacation programs that provide food service similar to food service made available to children during the school year under the school lunch program. So that is a very long-winded way of saying that in order for meals to be reimbursable when served through the summer food service program, those meals must be consumed in a congregate setting. So that means that all the kids are sitting in one supervised location consuming their meal. Meals that are taken off-site are not considered reimbursable. And so we understand that in a hospital or healthcare setting, this can get tricky. You know, the kid might have to come and get their meal and go back to their room, and that would technically not be considered reimbursable. There are some flexibilities that have been provided in the past. If this is something that you are interested in, we highly recommend working with your state agency to see what parameters you would need for your program. The model that we have seen work really successfully in hospitals and healthcare centers is having the kids come down to the cafeteria. Most hospitals have a cafeteria, and, you know, the kids can go through the line and get a ticket and, you know, be served, you know, a hot meal along with the other patrons of the hospital cafeteria. That's one thing that we've seen work really well, and you will definitely hear more about other successful models later in the presentation. But I did just want to point out that this congregate feeding requirement is a requirement of the program, and one of the things that we see cause the most amount of consternation in the program oftentimes. So next I'll talk a little bit about transitioning from our summer programs to our at-risk programs. As part of our child and adult care food program, we also have an at-risk after-school component. A lot of times, organizations will typically operate both programs, so that way they have year-round feeding for children who are in need. The intents of the program are different. The at-risk program is intended to provide care to children outside of school hours. And the intent of the SFSP is to provide meals when school is not in session. Both operate in low income or areas of poor economic conditions. And the administration is similar. There can be sponsoring organizations or independent centers in both. On the next slide, I will talk about the biggest difference between the two programs that also we see trips people up sometimes, especially we have heard some issues in healthcare settings about the activities. So part of the regulatory requirements for the at-risk program is that the program has to provide an organized, regularly scheduled activity that includes an educational or enrichment activity. So in order to provide meals that will be reimbursed through the CACFP at-risk program, there has to be an activity available to the children. There is no such requirement in SFSP. While we do encourage activities during the summer, there's no regulatory requirement in order to make those meals reimbursable. So we have heard in some instances, you know, there might be a WIC clinic or something like that where they say, oh, well, we put on, you know, Sesame Street for the kids to watch while they're here, and we serve them their at-risk after-school snack. That would not typically be something that we would consider an organized, regularly scheduled activity. There are guidelines on this. We have an at-risk handbook that folks can take a look at if they are interested in operating both programs. But I just want to highlight that this is an area where sometimes people run into some issues. So on my last slide, I just want to leave some final thoughts, things to keep in mind as you are mulling over whether or not you want to participate in this program. So first, eligibility can be established in a variety of ways. We do have traditional methods. However, like I mentioned, we do approve other sources. So if you have a location in mind that might not necessarily meet the traditional eligibility requirements, you know, we encourage you to work with your state agency to see if there might be another approved method of determining area eligibility. Again, the meals have to be served in a congregate setting. This is a requirement that is in the statute. People ask me all the time if we can, you know, change the rules of the program to allow for some flexibility in there. Unfortunately, when Congress is the one giving us those rules, that is not something that we have the power to change. So meals have to be served in a congregate setting. One other thing that I wanted to touch briefly on is that sponsors must ensure that all sites are in compliance with all local health and safety requirements. And, you know, again, work with your state agency on that, and just highlighting the differences between summer meals and the at-risk after-school programs. There are differences. Your state agencies can really help you work through all of these kinks. So just really want to encourage anyone who is considering participating in the program to reach out to their state agency for more information. Thank you very much.
Thank you so much, Emily. I have a quick follow-up question. You know, you talked about the congregate meal requirement, which, as you mentioned, is governed by statute and something that USDA manages through regulation, but it actually is instituted by law through Congress. So it's something that folks are going to, want to navigate as they explore implementing this model in their communities. And as with any new environment, it calls for close engagement with the administering state agency to make sure that everyone's on the same page, ensure compliance, and make sure there are no unpleasant surprises once the program's underway. Can you give folks a few pointers on how to initiate and prepare for those conversations with state agencies to make sure they're very clear about their intentions and that everyone's on the same page from the very beginning?
Sure. So USDA has a lot of really wonderful resources that can help get you acclimated to the program and think through what you want your program to look like. We have a wonderful one-page handout on how to participate in summer meals that's located on our website. We also have a really great administrative guide for sponsors, and it walks through step-by-step in a really easy and digestible way the requirements for the program, things to consider when operating your program, and how to interact with your state agency, what the state agency is responsible for, and what sponsors are responsible for. We also have a wonderful toolkit section on our webpage that covers topics from how to budget for your program, how to provide activities in your program, how to stay within the requirements of the program, and that is also located on our website. So I guess my recommendation would be to review some of these materials before approaching the state agency, just to make sure that you are familiar with the program, and also thinking through what the needs of your community are. Every community is different and special, unique snowflakes, so we really want to make sure that programs are tailored to the needs of each specific community.
Thanks so much, Emily. And we can send out a link for those, the administrative guide and the Summer Meals Toolkit that you mentioned. We got a question from Catherine in Washington about how USDA defined a health center site. They mentioned that they had sponsored a community health clinic site at a community health clinic, but didn't see it on the map.
Okay.
So not sure if you have any insight offhand, but just wanted to put that out there and see how that was defined.
Yeah, so the map that I showed at the beginning of my presentation was sort of some back of the envelope analysis that we did. USDA has developed a wonderful tool called the Summer Site Finder. So during the summer months, it's a tool where families, parents, children, communities, teachers, caregivers can go online, type in their address, and find the closest summer meal site to them. So the way we used that data for this map was we searched for sites or sponsors that had hospital or healthcare center in the title. So it's not necessarily 100% accurate. It's more back of the envelope, just to give an overview of sort of, generally what the space looked like. We also have another wonderful mapping tool called the Capacity Builder. And so this would actually be something that would be great for folks who are looking to get into the program to use. It contains multiple layers of data. So there's the addresses for school sites, churches, libraries, museums, and federally funded healthcare centers as well is one of the layers in that map. And it allows you to go in and see where sites are currently located and where there is opportunity to locate sites in areas where there might be some gaps in access.
Thank you so much, Emily. And we'll also be sure to send out a link to the Capacity Builder. And I see we've got a few other questions here. We're going to move on in the interest of time, but we have time set aside for a moderated Q&A at the end to try to get to everyone's questions. So, Emily, thank you so much. Very valuable to have the USDA perspective on summer meals generally and on as it applies to this model. And with that said, we are going to turn our attention to the plethora of models that are out there. And for that, we have Debbie Putti-Payne, Sodexo Wellness Dietitian with the Medical University of South Carolina. She is the Wellness Dietitian in the Office of Health Promotion, where Debbie develops policies and programs to advance health on the MUSC campus and in the community. In her work as a dietitian over the last 11 years, she's provided direct patient care to those undergoing dramatic diet and lifestyle changes in an effort to lose weight, improve medical issues, and get healthier. She graduated from the College of Charleston, received her master's in nutrition from Boston University, and completed her dietetic training in Honolulu, Hawaii. and has done a lot of work to raise awareness about summer meals within healthcare institutions in recent years. Debbie, thanks so much for joining us. We're glad to have you.
Thank you all for having me so much. The very first slide that I have here talks about the prevalence of hunger in America. Yes, that's the one. And for the audience that is on the line, it sounds like most of you work in this space, and this is not new information to you. In fact, you're the ones going out there and sharing that information with everybody else. But the reason I always include this in the presentations that I do from a healthcare perspective is that framing the prevalence of hunger in America when you're talking to hospital administrators can be very powerful, particularly when you talk about the rates in your own community. So, defining what food insecurity is, talking about the number of people that struggle with hunger, and of course, how that directly connects with our children. But on the next slide, you see some statistics that are really interesting about the connection between hunger and health that come from the 2016 Hunger Report. And this is the information that I find really starts to engage the healthcare administrators in this conversation. And that is saying, yes, everybody cares about hunger in their community, but why should you as an administrator from a business perspective position the hospital or the healthcare institution in the fight against hunger? And most hospitals will respond to the financials of that. And the Hunger Report connects food insecurity with the national health expenditure, currently at the estimated amount of $160 billion. And just a few years ago, that was 130.5. So that's a really big number that starts to get some attention. And if we can connect as well the prevalence of chronic health diseases that are nutrition related with the people who suffer the most from food insecurity, that's impactful as well. So in the report, we've got these statistics that of clients who use the Feeding America network, 70% of the households have at least one member who have high blood pressure, 47% of households have at least one member with diabetes, and 75% of their clients have to choose between paying for food or paying for healthcare. Personally, this was a statistic that was really staggering for me. As a registered dietitian, I believe in using food as part of your medical therapy, but when you don't have the resources to really pick and choose or be specific about what it is you're putting in your cupboards, it makes it really difficult for me to do my job from a clinical perspective. On the next slide, it talks a little bit about how SFSP, the Summer Feeding Program, really offers this opportunity for healthcare organizations to get started in this space. And so a lot of hospitals, once they see that financial data and they hear your story and they decide they want to get involved, they see the economic sense that it makes. Their next question is, but where do we start? This is not our area of expertise. And so one of the best things that we can do is offer them an existing food and nutrition program that also has a dedicated funding source and say, here, do this. Operate a program like this in your institution. And they might say to you, but why should we do that? Other people offer summer feeding programs. And so the statistics about national participation rates can be really helpful. First of all, just reminding the hospital that kids, when they get out for summer, they are at increased risk during that period of time for both malnutrition and obesity. There are still a lot of people who find those two conditions to be opposites, but we recognize now that they are both expressions of the same underlying factors. And pediatric obesity is something that we work really hard in the healthcare industry to get our arms wrapped around. And at the same time, of the children who qualify for free or reduced price lunches during the year, very few of them actually participate in the summer feeding program. Depending on your particular state, it's going to be somewhere around 20%. And I'm sure the reasons why you don't have more children participating is multifactorial, including things like lack of transportation, not knowing where the closest location is, unsafe neighborhoods. But one of the areas of opportunity to get more participation is to bring non-traditional spaces into this program and offer summer meal programs in these non-traditional spaces. And we've seen this work recently with libraries, for example. So it just sort of makes sense then that the next space should be hospitals and healthcare organizations. After all, we're there 24/7, 365 days a year. We definitely know how to feed people because we do that all day, every day, even when we're closed down for hurricanes or ice storms or snowstorms. That's the strength that we really bring to the table. So on the next slide, you'll see a map that I have that's similar to what Emily showed you. And if you are participating as a healthcare organization and don't see your name on here, I would love to talk with you and get you on this map. Carolina's health system in Charlotte is at the very bottom, but they seem to be cut off the slide. But essentially in 2015, during my work at the medical university, and we realized that this was an opportunity for us, we wanted to start summer feeding, we went out and combed the landscape to try to find other institutions that were doing this that we could lean on for their best practices. And it took a while for us to tease out some examples, which are listed here. But since we've moved forward, we've been really lucky in working as sort of an internal network in sharing our lessons learned and helping each other up and doing site visits with each other. Derek mentioned the implementation guide, which you'll get a copy of. And you can see that participation's grown by about 250% just in the last few years. On the next slide, the next slide actually shows a couple of pictures from my institution. But what I wanted to do was show you how there's different ways that you can actually operationalize summer feeding in a healthcare institution. So in going around and collecting the stories of those institutions from the previous slides, what we realize is that there's a pattern, that they're sort of collecting themselves into different buckets of ways people are operationalizing this program. And in a high level, that's what I wanted to share with you next. At MUSC, we actually do the offer versus serve site or method. And so when we started the program, we had no dedicated FTEs. And so we needed to be able to allow the customer to navigate by themselves the flow through the cafeteria. So we created this cute little purple octopus mascot, and the idea was you sort of follow the octopus through the cafeteria. Our cafeteria is like many hospital cafeterias. It's very large. It's incredibly busy. It has a lot of national chains in it as well, including a Mexican outlet and a Chick-fil-A, a self-serve salad bar. So really trying to point the children to the line where the approved options would be, in part so we could make sure that they created a plate that met their criteria as required by USDA, but also to make sure that we could control the food cost from our end. So you can see at the top right, that picture is our hotline. We offer 3 entrees a day, 2 different grains, which is the macaroni and cheese and rice, and lots of beautiful different colored vegetables. And our staff works with the children and basically says, you know, hey, are you here for our free meal? As an open site, we can serve any kid who's 18 and under, so we can ask the same question to every child. And if they say yes, then our servers help to make sure that they get the right combination of foods so that they meet the criteria. And then they are going to go to the register, which is the bottom middle picture, where our cashiers verify the plate by using our point of sale computer system, which has them go through one food group at a time to make sure that they are selecting something from the required component. And then this is a cute little picture of a child sitting in our dining room where they are eating the food after. And as you'll see, we actually serve greater portions than what the USDA says is the minimum, in part because that's just our standard portion, and we didn't want the servers to have to dish out anything differently for the children than they do for every other customer. And one of my favorite things about the offer versus serve is that these children are going through the exact same hotline and the exact same register line as our doctors, our nurses, our medical students, and everybody else. So they are treated exactly the same. The difference really is just at the register system and who's picking up the tab. On the next slide, you can see that this is an example. ProMedica is from Toledo, Ohio, where the hospital served as the sponsor and the site, which we did at MUSC as well. And I know that Emily said maybe this isn't where you want to start, but they've been successful at doing this. You see that picture on the bottom left, they offer a hot unitized meal, but it's made to order. From the grill station. So they already know what their menu is going to be. They know they're going to have all of the required components. The child goes up to the grill and says, hey, I'll have, this free meal today. And then they make it to order so it's hot and fresh. And they use really nice posters throughout the cafeteria to help direct the flow. They were very successful in their first year, and so in the second year, they expanded the program into one of their community hospitals in rural Ohio. And the number of children that were fed in 2017 at that hospital was not very large, but the hospital was serving kids that really had very few other options in this part of rural Ohio. So sometimes it's not really a matter of how many kids you're serving, but are you providing an option for those children when maybe they don't have another option? On the next slide, you can see an example from Carolina's healthcare system in Charlotte, where the hospital decided that they were going to be the site only. And one of the reasons the hospital was the site only is because they started their program too late to apply to be a sponsor. So they missed the June 15th deadline. And that ended up, I think, being a blessing for them, because what happened is they ended up, their state agency actually helped to pair them with a sponsor that was willing to take them on as a site. So then they could really focus just on getting the operation up and running. And it allowed them to get in before the end of the summer instead of just saying, oh, well, we'll wait until next year. And they got a few weeks of practice essentially underneath their belt that they then have been able to learn from and move forward with as they prepare for going into the summer this year. On the next slide, you can see that another option is actually using unitized meals, which I think a lot of people think of as the classic model when they think about a summer meal program. Arkansas really holds the gold standard for summer feeding programs in general, but definitely for this unitized meal program. They've been operating the program for a really long time, since 2013, as both a sponsor and a site, and they have volunteers who line up in an assembly line to pack up their cold sack lunches that they then have in a cooler, and the children then are able to grab the unitized meals that way. The picture on the bottom left is actually from one of our oncology clinics where we tried this unitized meal program in addition to our Offer versus Serve program for our children who were coming in for cancer treatment, and it wasn't recommended that they go down to the cafeteria because their immune system was depressed. So we actually brought on this clinic as another site, and were able to drop meals, unitized meals to them, and our nurses helped with distribution. And I think that's a really nice example of, if you've got one particular area or you want to start at a smaller scale, identifying a particular clinic. For some hospitals, the ED is a really important area to try to offer this service, and just doing unitized meals in that one area before you open it up across campus. On the next slide, we also have an example of university hospitals, and they're going to be able to tell you more about their model in depth. So I don't want to steal their thunder, but I do have them listed up here as an example of a program that uses a voucher system. So the patients or the children actually get a ticket that helps them to communicate that they want the free meal, and also to communicate that to the cashiers. And they're doing a great job expanding the program as well. So I'm going to let them talk more about that in a moment. But the last slide that I have as an example of how to do this is at MUSC one summer, we also provided meals outside from our half-acre farm. And I like to use this as an example to tell people, if you don't want to drive children into your retail space, if it is overwhelming for you to think of having more people in that space, it's true that a lot of hospitals have cafeterias, and it's almost always true that none of them are big enough for all the people that come through there. Or the cafeteria is positioned in a place on campus where they don't really want folks that aren't supposed to be on campus to come there intentionally, whether it's on a different floor or buried deep in a building. So just don't forget that as long as you're meeting all of those health and food safety requirements, you can distribute meals from a non-traditional space. For us, it was our urban farm, and we did that in partnership with our Low Country Food Bank, which actually served as our sponsor for that. And that is our USDA regional office came down for the launch of the program. But we've also seen it in hospitals where unitized meals were distributed from the Ronald McDonald House, or a very specific floor, or even an outlying clinic. So if you get overwhelmed by the idea of driving people into your retail space, consider the fact that you could actually distribute meals from somewhere else. And then on the very last slide is just the link to the implementation guide. We're really fortunate when we realized we didn't have a lot of other institutions to look toward to receive a grant through No Kid Hungry to create this implementation guide and help document a lot of the different models that are out there so that other institutions had more of a starting place than we had. And we do try to update it on an annual basis. And I'm also happy to talk one-on-one with anyone who needs more information. So Derek, thank you for your offer to include that link in the final materials as well.
For sure, Debbie, and thanks so much to you and your team. First and foremost, for operating the program, for serving kids in your community, and then for the work you've done to connect folks in this space, and also to make this implementation guide available to folks. We'll definitely be sharing that out. I have a couple questions that have come in. We'll save those to the end when we get to the moderated Q&A session. At this time, we are actually going to move on to our next presenters. As you mentioned, Debbie, we're fortunate to have Ann Leach and Dan Ballard from University Hospitals Cleveland Medical Center to talk about their program. Ann is a registered and licensed dietitian who joined Sodexo in 2008 and is currently working as the community program director and wellness dietitians for the University Hospitals healthcare system. As the community program director, Ann is responsible for not only identifying community programs to implement, but also developing the vision and leading the ongoing efforts to deliver a market-changing community support program. Prior to her time in this role, she was the systems general manager for Lake Health Hospital System located in Northeast Ohio, and holds a Master's of Science degree in nutrition from Kent State University and a Bachelor of Science degree in dietetics from Ohio University. Dan, district manager with Sodexo, is responsible for leading the Food and Nutrition Services Department at University Hospitals. Dan has over 10 years of experience developing and leading strategic initiatives in healthcare with a strong focus on delivering high-quality, outcomes-based service programs within university hospitals. Dan's a certified food service management professional and attended the University of Toledo. Dan and Ann, thanks for joining us and for sharing your story today.
Absolutely. Thank you so much for having us. It's been great so far. So, every day Sodexo serves hundreds of thousands of nutritious meals, yet, as we've heard from Emily and Debbie, close to 15 million children are still at risk of hunger. And as we know, young children who are screened and at risk for food insecurity are more likely to be in poor health, more likely to have been hospitalized, and more likely to be at risk for developmental delays. Unfortunately, hunger among our youngest Ohioans is growing and will dramatically affect not only rising healthcare costs, educational achievement, and future worker productivity. So a little bit briefly about University Hospitals. We're a large health system located in Northeast Ohio. And some statistics that I think Debbie had mentioned and Emily as well that are important for individuals willing and interested to putting this program through is to really understand what the local hunger and food insecurity impact is in your area. So as you can see on the slide, 1 in 6 residents from the 6 counties that make up Northeast Ohio are food insecure, which is more than 1 in 5 children living in a food insecure household. Cleveland is located in Cuyahoga County, which has the highest number of food insecure residents in the state of Ohio, and is also home to the largest number of food insecure children in the state of Ohio at 58,370. And then I'll turn over for the next slide over to Ann, who will tell you a little bit more about our program.
Thanks, Dan. So we actually heard about this program from Debbie at MUSC and wanted to implement it at our institution. We approached one of our physicians, Dr. Aparna Bowl. She's a pediatrician at UH's Rainbow Babies and Children's Hospital, as well as the medical director of community integration. So she was aware of the program and was extremely excited that we wanted to implement this program at Cleveland Medical Center in 2017. We partnered with the Injury Prevention Department, which is located inside of Rainbow Babies and Children's Hospital. We worked closely with this team to complete the application process, identify throughput and flow of children, and also the tracking methods of the program. We created educational materials. Since for the injury prevention program, they do a lot with car seat safety, pool safety, and we also incorporated healthy eating. Rainbow's mascot is Bo the Care Bear, so we use that to market throughout the hospital and help guide the children and parents throughout the process. So you can see Bo on the flyer there, the Kids Summer Lunch Program. And as Debbie mentioned, we also use vouchers, and the vouchers had Bo the Care Bear on it. So they would come to the table and check in with the volunteer that was watching the area where the kids eat. And then they would follow Bo the Care Bear throughout the hospital, or throughout the cafeteria, where at each station where the food was that we were serving. and then provide the voucher to the cashier. And we served 3,136 meals in 10 weeks. And on the next slide, I'll talk about best practices, lessons learned, and expansion. So best practices is partnering with the additional departments, much like we did with the injury prevention department, to help market and then provide education to the children. Also using a mascot or an animal or another type of a visual aid to help market and direct the children and their parents throughout the cafeteria. If possible, to utilize a point of sale system to track product sales and production needs, as well as the number of children that were coming through the cafeteria, and take advantage of current menus to minimize change in job flows and labor costs. So we went off of our 5-week menu cycle and used entrees that we were already serving. We also posted the menus 1 week at a time so that the parents knew what their food options were throughout the week and then could decide if they wanted to come back to our institution. Some of the lessons learned is to start the application process early. There's a lot of information needed, but as we continue this process this year, we have found that it's much easier to complete as a returning site. Also for food preferences, knowing your population and keeping religious restrictions in mind. For example, serving pork products, we found that many children don't eat pork, so that was good to know, and also using simple menu verbiage. Our employee engagement increased dramatically as staff learned about the program. So on to expansion. We will be expanding to 5 additional locations this summer. We are a system of 12 hospitals, so we will be doing the summer lunch program at 6 locations. We are adding breakfast at Cleveland Medical Center and increasing our marketing efforts internally and externally, as well as marketing our program at local schools and churches. So the injury prevention program also goes out and educates children at the schools, and we are going to use that to our advantage this year and really market the program prior to the end of the school year. And that's all I have. Thank you.
Great. Thank you, Ann and Dan. And again, as we go on to our next slide, just reminding everyone we have a moderated panelist Q&A. We've got a lot of questions here. We're going to try to get to as many of them as possible. I have a question, Ann and Dan, I know it from conversations, you mentioned that, your team had initially brought the idea of summer meals to hospital administration who were receptive to this proposal. What were some key selling points? And I know, Dan, you mentioned some of the top line statistics in terms of food insecurity in the area, but what were some key selling points that really worked to help get buy-in from hospital administration to pilot this program?
Well, I think, as you had mentioned, having the information available to you regarding the food insecurity in the area that the hospital or the healthcare institution provides care for is really important, and that information is really easy to get. We were able to find quite a bit of information just in talking to our Greater Cleveland Food Bank, who does a lot of analytics and has a lot of statistics available. They were extremely helpful in having that information, and most of our healthcare administration already understand the effects of food insecurity on not only their current patients, but our goal ultimately is to make sure that they're not going to become patients for a hospital. So starting with children was such an easy thing, easy concept for them to buy into. So it was extremely helpful in that way. The other piece is they quickly realized that there's much more of a benefit. Not only are we providing nutritious meals for these children, but this may also help a lot of the food insecure families that have trouble making and keeping their physician's appointments and scheduling regularly scheduled checkups. So they are looking at this as an advantage. And one of the things that we hope to do after we've completed our baseline year is really be able to track the number of appointments that are scheduled with primary care physicians, the number of appointments that are kept versus being canceled or individuals are late for, to really be able to see that there's also a correlation that we're promoting general health care and well-being, not just nutrition and food insecurity.
That's great, Dan. And just kind of shifting gears, but still thinking about your program, we got a question from Alex in the audience about any recommendations for working around janitorial and waste duties tied to the program. Did this present any change to your normal operations, or was there any pushback around the summer meals program specifically?
That's a great question, and the answer is simply no. And we were able to incorporate this program with no additional food costs, no additional labor expenses. And in fact, as Anna had mentioned, our employee engagement skyrocketed because ultimately we're working with the community. We're helping the community, and our employees work in the community. So they understand some of the struggles that their friends and family members and individuals they see at church go through on a regular basis. So we saw many employees that were going above and beyond to try and help and direct and answer questions. So not only did we see no increase in those expenses, we also saw an increase in employee engagement. So it was really a win-win for us.
That's great, Dan. Emily and Debbie, I'm going to send each of you a couple of questions quickly so we get in under the wire here. I'm going to start with Emily. Emily, there was a question that came in. Do children need to be patients to participate in these programs at summer nutrition programs at hospitals or healthcare institutions? And kind of an associated question, or a kind of a question in parallel is, there's a lot of questions we're getting about the SAC lunches and how that works with the congregate requirement, or what does it mean to be in a congregate setting? Some things people should be thinking about. I know you touched on that earlier, but could you revisit some of those? A, about do kids need to be patients? And B, what are some recommendations for managing that congregate meal requirement to make sure folks are in compliance?
Sure. Those are both really great questions. So to tackle the first one, whether or not kids need to be patients, that really depends on the type of site that you are running. So if you're running an open site, that means that any kid from the community, 18 and under, can come in and receive a meal. If you do have certain, like I said, fire safety restrictions or things like that, you might want to consider opening or operating a restricted open site or a closed enrolled site, in which case you would only serve children that are patients of the hospital. But again, that's something you'd want to work through with your state agency. You are more than welcome to open it up to the entire community. If you know that there is, community right next door to the hospital that might benefit from this program, you're more than welcome to advertise to them and, have folks from the community come in to receive free meals. In terms of the congregate requirement, what we typically say is you can decide if it's congregate if the kids are being supervised. So, if you can make sure that, the kid is not choking on their food or, stashing food away in their backpack to take off site, that's typically the way that we gauge congregate settings, is that the children have to be supervised. And I really loved the example that Debbie gave of, they sort of opened a satellite site in, their oncology clinic because those kids couldn't necessarily go down to the cafeteria to receive a meal. That's a really great way of doing that. So typically with the congregate, we just want to make sure that the children are in a supervised setting.
Thanks so much, Emily. And Debbie, I'm going to jump right over to you. We had a question come in from Alex about how were you able to ensure that kids actually took the required full reimbursable meal when they were at your site participating in the program? And additionally, can you give a little just a little bit of insight on how this program impacted your cost structure in terms of food and labor costs? Did this operating the summer nutrition program lead to an increase in labor costs or other expenses, or did you find it to be generally, what did you find to be the financial impact of operating the program?
So thank you for those questions. They're great. And I'm going to tackle the second one first, which is that the financials was actually a key component we had to monitor in the first year before leadership could sign off on doing it again. And so that's how we ended up doing offer versus serve, because with that model, we didn't need to do anything differently than our normal operation. So we didn't have to build in additional staff or labor around food. So similar to what Ann and Dan saw at their site, because we were essentially finding a way to make the program work within the construct of how our retail space operates, that was able to keep those food costs under control. And because of our computerized point of sale system, we were able to capture how many of each entree we were actually giving to the kids that year, so we could on the back end go through and do some food costing analysis to make sure that we weren't losing money with the USDA reimbursement. And so as far as making sure that they are getting all of the required components, so we Offer versus serve is a lot harder to train your staff on than it is to actually do, because you do have to still offer all of the required components, but the children are allowed to decline a couple as long as they still end up with a certain number and a certain combination. And so it's really a matter of training the staff around what combinations are acceptable. So we turn that into a game during our required training, where everybody gets a different plate and they have to talk about whether or not it's reimbursable or not. And they pick up on that very quickly. I think the biggest thing is, in the South, we think of potatoes as a starch, not a vegetable, and that gets them almost every time. But then there's the double check of having the cashier actually look for each component in the meal in the computer system when they're bringing them up. So on the first screen, it'll say, do they have an entree? And, our entrees are going to include meat most of the time. On Meatless Mondays, when we don't have meat or beans in it, that would be one of the few examples of things that the children would not be allowed to select, since it wouldn't be part of the reimbursable meal. And then it goes to the next screen where do you have a grain, et cetera, et cetera. And so it's worked really well. And the last nice thing about our computerized point of sale system is that we can go in on the back end and we can look at all of the buttons that our staff picks. So if we see a combination that's wonky right there, we can give immediate feedback and go back to the staff and say, hey, listen, this combination that you punched in, it doesn't count. Can you tell me more about what happened? And we can use it as a on-the-job training opportunity, and then we just don't count that meal toward our USDA meal count. And coming now through so many years of doing this program, similar to what Dan said, our staff loves this program. And from the moment we stop it in August, they ask me, how many more days until we do it again? How many more days? And so they train each other and they support each other as well, because they want to make sure they're maintaining the integrity of the program.
Thank you so much, Debbie, for that. And I want to just take a moment and thank Emily with USDA, Debbie with Medical University of South Carolina, and also Ann and Dan with University Hospitals Cleveland Medical Center. Of course, those last three working with Sodexo. I want to thank everyone for their expertise and for taking part. And for all of you for joining today, I want to invite everyone to join us next month as we just explore partnership with universities to build summer meals capacity on Tuesday, April 24th at 2 p.m. Eastern. You'll receive additional information and a chance to register alongside all of the resources that we came up today that we'll be distributing to everyone who registered, and also those who attended today's webinar. Thanks so much for joining us today. Good luck in all of the upcoming planning activities. Don't hesitate to reach out and to use our website as well, bestpractices.nokidhungry.org. On behalf of the No Kid Hungry Center for Best Practices, I want to thank you for your time. We look forward to joining you again next month. Have a great day.